Parameters of biological sex. There have been 5 parameters, but now brain sex has been added. Chromosomal sex, gonadal sex, hormonal sex, internal sex organs, external sex organs, and now brain sex. The term XY equals male and XX equals females is now obsolete and is not always true, because you may have sex reversal syndrome, you may have XY female or XX male due to translocation of SRY gene from Y chromosome to X chromosome. Hormonal sex, by default, the development of the reproductive system is female. I say female and not ovary, because the ovary does not rise by default. It needs 2 copies of X chromosome. Differentiation of male ducts depends on the action of androgens, and development of female ducts is inhibited by anti-Mullerian hormone, which has been called anti-Mullerian substance. Normal ovarian development needs 2 copies of X chromosome. Biosynthesis of testosterone by Leydig cells requires 5 enzymes. In target tissue, testosterone should be converted to dihydrotestosterone by 5-alpha reductase deficiency, which has greater affinity to receptors, maybe 5 times or more than testosterone. Proliferation of Wolfram ducts requires testosterone, and the proliferation of external genitalia requires dihydrotestosterone. Brain sex, which is now new, androgens have defeminizing and masculinizing effect on the development of brain. Defeminizing. Exposure to androgens programs the hypothalamus for the constant male sex hormone versus the cyclic female sex hormone. Because male sex hormone is constant, this has the effect on the brain, which is called fingerprint of androgens on the brain. Now, what is sex? It refers to a person's biological status and is categorized as male, female, or intersex, something in between. Indicators of biological sex, as we said, are 6 chromosomes, gonads, internal and external genitalia. What about gender? Gender is the attitude, is the feeling, is the behavior that a given culture associates with a person's biological sex. Behavior that is compatible with this culture is called gender normative. And if it is incompatible, it is called gender nonconformity. It will be different. It is one thing to have vagina, breast, ovaries, XX karyotyping, but it is another thing to be female. It is another thing to be feminine. It is another thing to be a woman. Gender assignment occurs at the birth, denoting the beginning of gender socialization. Sexual identity is the inclination of the child to feel being a male or a female. But gender identity is the attribution by society, that is gender assignment of a male or female rule to the individual. So sex is quite different from gender. Ambiguous genitalia, as you all know, is a situation where there is discrepancy between where the external genitalia are not clearly male or female, something in between. Either insufficient virilization of a male or virilization of a genetic female. But intersexuality is the genetic sex, gonadal sex, and genital phenotype are not concordant, does not conform with each other. Sometimes there is intersex without ambiguity, like in case of receptor deficiency. Classification of intersex. This is the old classification by Allen in 1976. It depends on the gonads. If you have 2 ovaries, it's called female pseudohermaphrodite. 2 testes, male pseudohermaphrodite, as you all know. Ovary plus testis, true hermaphrodite. Testis plus streak is called mixed gonadal. Streak plus streak, pure gonadal. This is the diagnostic algorithm proposed by Griffin in 1992. It is an easy algorithm which is applicable till now. According to physical examination of the genitalia, external genitalia, if you have 2 gonads, 1 palpable gonad or no gonads palpable, and you will go through karyotyping, and it gives you all of the 6 varieties of intersex. Recently, Chicago consensus classification is based on the primary genetic defect, either 6 chromosome disorders, 46XX disorders, or XY disorders. 6 chromosome disorders, mosaic pattern 45XO, 46XY, low mixed gonadal dysgenesis, or ovotesticular DSD, or Turner syndrome and Klinefelter syndrome, 47 double X or triple XY. I will go through these slides rapidly because it is well known. XX DSD, either androgen excess. The best example is adrenal hyperplasia, and rarely maternal androgens, and disorders of ovarian development, ovotesticular DSD, and testicular DSD, XX reversal, or pure gonadal dysgenesis. Deficient androgen synthesis, you will find low testosterone and dihydrotestosterone, normal anti-Mullerian hormone. Variable phenotype, testis is in labioscrotal fold, inguinal or abdominal, Wolffian derivatives normal or hypoplastic, and Mullerian structures are absent. 5-alpha reductase, I will concentrate on this topic. There will be normal testosterone and low dihydrotestosterone. I mean high ratio testosterone on dihydrotestosterone. At birth, as you know, but at puberty, there is spontaneous viralization. So we should not rush to assign gender, because the picture may change in adulthood. At puberty, there is spontaneous viralization, the phallus enlarges, labioscrotal folds become pigmented, testes enlarge and descend. Some individuals initially raised as female adopt male gender at puberty. The cause is increase in testosterone and the presence of non-genetic 5-alpha reductase. This is a very important issue. Complete androgen insensitivity, as you know, it is 46XY, female external genitalia, so there is no ambiguity. Absent Mullerian structures, absent or vestigial Wolffian structures, testes inguinal or intra-abdominal, breast is developed at puberty, and viralization at birth does not occur. Partial insensitivity, in this case, also in adulthood, there may be change in the picture with benign growth later on. Timing defect means 46XY karyotype with ambiguous genitalia, but normal production of testosterone and dihydrotestosterone at puberty, and normal response to androgen at puberty. This is due to delayed differentiation of Leydig cells. Ovotesticular DSD, which has been called true hermaphrodite, most of the cases are XX, and they have ovarian tissue and testicular tissue, and most of the cases have one ovary on one side and the ovotestis on the other side. Pure gonadal dysgenesis as variable karyotyping, sterete gonads bilaterally, normal uterus vagina tubes, phenotype normal female, so there is no ambiguity. Disadvantages of this classification is that karyotyping might vary among individuals in the same condition. So there is another classification, Arson classification 2010. It is based on gonadal status, so it is the same like Allen classification. It is based on gonads. But the difference is, in Allen classification, they say hermaphrodite either true or false, but here we call disorder of sexual differentiation. This is Allen, and this is Arson, the same. I will go through this clinical examination with history taking, genital examination. This is features of normal male, normal female. Karyotyping should be done in the first day. Chromosomal analysis from other tissues to exclude mosaic pattern. This is important. Most of laboratories do only karyotyping. No, chromosomal analysis of the fragments of the chromosomes, fragment of Y chromosome is very important because there is high incidence of malignancy if a fragment of Y chromosome is present in cases of Turner syndrome. Hormonal analysis, 17-hydroxyprogesterone should be taken as a screening test for all newborns to exclude congenital adrenal hyperplasia, which is the commonest variant of intersex. Also plasma levels of testosterone and dihydrotestosterone. Radiology, cystoscopy, laparoscopy. Gender assignments, that's very important. The old paradigm, gender assignment in the old paradigm was considered a psychological emergency, psychological to the parents. Surgery should be done in the old paradigm early so that anatomy would conform with the assigned gender. The decision to raise a child as a male needs a potentially active phallus to function. This created what's called the gender dissatisfaction, which is unhappiness with the assigned sex, even among individuals without DSD. Disturbed sexual identity means dissociation between physical sex or biological sex and mental sex. This is due to fingerprint of androgens on the brain. The new paradigm, there has been tremendous change in clinical practice, in terminology, in medical and psychological attitude. Anatomy is not important in this paradigm. Gender assignment is fluid. I mean, not definable. Decisions made by a multidisciplinary team, communication with the parents and families, and self-return should be respected. Parameters of optimal gender policy: good sexual function, reproductive potential comes second, minimal surgical procedures, an overall gender appropriate appearance, a stable gender identity and psychological well-being. I will present this case and it will be open for discussion after this talk. This patient is 27 years old, reared as female from a rural area in Mansoura. Reared as female with extensive viralization. Karyotyping XX. Uterus and the tubes. Hormonal analysis: 17-hydroxyprogesterone elevated 11.5 and raised adrenal ACTH hormone. So this is a case of congenital adrenal hyperplasia. Reared as female and left till now, till the age of 27 without any treatment. طبعا she is not salt losing. She wants and she is eager to be male. Our policy all over the world is to manage adrenal hyperplasia XX as females. Should we manage this case as female or turn her male, according to her desire. I have already said that the desire of the patient should be respected. And now she has extensive viralization. What to do with this case? I will finish my talk. It is easy to diagnose, easy to manage, but it is sometimes difficult to decide. Thank you very much.